is a meta-analysis decided that paratuberculosis in Crohn's disease, based on PCR, ELISA, is well established, 7 times more perhaps, despite all the problems that we've had. So paratuberculosis is more likely to be in Crohn's patients if we use the right tests and do it the right way. Even up to 80% of Crohn's patients can be found as MAP positive, but 40% of non-Crohn's patients, normal patients, can also be found as MAP positive. This is a significant finding, not only in the non-sterile sites, but also in the sterile sites as well. We're having active, invasive MAP infection going on in normal patients. MAP is definitely infecting patients and humans. What about culture? Well, culture is a problem, particularly in humans, which is one of the major problems we've had. And the reason I think that occurs, and has been a problem, is because paratuberculosis has a phenotype that is very, very easily activated, and this is a viable, non-culturable phenotype. So to illustrate this, I'm pulling up some of Richard Whittington's group's excellent data that they published this year, showing that, in fact, if you treat paratuberculosis with the repeated cycle shock syndromes, and then it moves the lag phase along here 2 weeks up to 5 weeks. This is forcing paratuberculosis into this phenotype, viable, non-culturable. It comes back, but it still forces it to increase. Does it happen in humans? That's the most important bit. So in our lab, we try to actually look to see whether that does happen. If you take paratuberculosis and put it into human macrophages, you get the carotid, it comes down, the CFU decrease, it kind of plateaus out down here. If you now look to see what the DNA is of the samples, it doesn't do the same curve, it comes up here. So there's a gap in here. So what's this gap? What's this gap for? Well, if we actually do a viability study, in this case, we're using a ribosomal turnover of each bacteria to show which ones are viable. All of these organisms in here, according to this, are viable. So what is this gap? This gap represents paratuberculosis going into cells. Some of them are still culturable, but a proportion of them are turning into viable, non-culturable phenotype. And it doesn't come back very quickly. It can only come back in about a year. So it's that long-term culture that you need to use because it's gone into that intercellular human phenotype. Also, most significantly, we also have the problem with Crohn's patients in the fact that this data here started around Greenstein and also carried out here by Mike Collins' group, showing that some of the samples that we're actually testing are inhibitory from MAP anyway, particularly from our Crohn's patients that have been treated with thiopurines. So we're actually not getting or even looking at the right type of predominance that we're seeing in our samples from our Crohn's patients anyway. What does this all mean? Put it all together just for the moment. Well, it means that MAP has a non-culturable phenotype on intracellular entry. This is helped by the fact that it also has an inhibition from some of the therapies it's been given. So it's actually not quite surprising that if you give immunotherapy, anti-TNF therapy, to a Crohn's patient, they actually don't get worse. And they don't get worse like happens in tuberculosis. Because in Crohn's disease, they have MAP. And MAP doesn't have the ability to recrudesce as tuberculosis does. And because it's in this viable, non-culturable form. So no wonder this particular argument against Crohn's and paratuberculosis is false. What are the lessons to learn? Negative MAP is not necessarily indicative of negative MAP infection, and you can't sometimes use some patients in Crohn's when you actually want to get a good data analysis. So it's very nice then to actually read this year of a good study, something that actually takes all these into account. This is Carl Kirkwood's work from Melbourne, from Australia, Melbourne. Here they're using 140 patients, that's a lot of patients, and they are paediatric patients, and they're coming in to their clinic, and they're prospective samples, so they're not treated. They're using a good optimized DNA extraction, they're using good controlled MAP-specific PCR, and importantly, they're growing the cultures for a long time, they grew them for a year. So actually what happens when they get the results for this? We see what we expect to see. Paratuberculosis is more likely to go into our Crohn's patients than in our normals. Also in biopsies, also in sterile sites, and if you took the positive cultures, you can actually grow the organism at the same time. So, MAP can And it actually does preferentially infect and persist in Crohn's patients if you do the right patients and if you do the right tests and look at it the correct way. But this isn't all the story. We're still not down the end of this line. I still need to show you that MAP and genetic susceptibilities are connected. And most importantly, we need to show this one, that MAP and chronic immune dysregulation are connected to make sure my story is believable. For this, we need to do a little bit more immunology. So I'm going to be very simplified here. I have to apologise to some of the immunologists here. It's quite a complex system. I've simplified it quite a lot. But in essence, what we have in Crohn's disease is a tissue damage and inflammatory response that's run by this Th1 bias and a pool of cytokines that actually occurs in correspondence to that. Well, actually, what controls this Th1 response is the most interesting point. What controls this response is an increased proliferation of Th17 cells. Now, we know this occurs in Crohn's patients because we can actually measure the Th17 proliferation by its IL-22 production, which we see increases in Crohn's patients extremely amount. We also can see IL-17 being produced and interferon gamma from these particular cells. We know these cells are proliferated and they are specific antigen, specific for their proliferation, and you need another set of cytokines, particularly IL-23, to make sure they work. Now, we also know that these are really, really important for Crohn's disease from the work that's actually been done by Dermot McGovern, who's now in LA, and Judy Cho, who's in Yale. And they show that, in fact, the mutations in these genes in humans, in the IL-23 receptor gene and the IL-17 gene, are protective for Crohn's disease. So what's happening here is that all this stimulation's going on, and it's not getting through here because this is dampening this effect, and this, if the mutation, is dampening this effect. So it's protective. We're seeing protection in this particular cell. This is where we need to get to if I'm trying to prove to you that MAP is going to cause this immune dysregulation. We also have risk factors. 3 major risk factor genes. Autophagosome here produces innate signaling. It sees bits of intracellular organisms, and this is what it does. Innate signaling, a little bit of apoptosis goes on. We also have the NOD2 gene, which I mentioned a little bit earlier. This is activated by MDP. This is muramyl dipeptide. Comes out of the peptidoglycan from any sort of organisms. And it also has another pathway which comes down through here to another set of cytokines that are affecting that are activating and killing of the cells, and also activation of different types of immune systems. So this is the system we're looking for. These are risk genes. We have to connect MAP to these risk genes. In my lab, we can actually see that if we put MAP into human cells, as soon as they go in, very, very rapidly, it increases the expression of the genes. Both ATG, MAP will push up, and also NODCARD15 will actually push up very, very quickly. If you look at some of the work that's been done in mice from Marcel Baer's lab, this takes it a little bit further. This shows exactly what's happening with this NOD gene. They've been doing some very nice work to show, in fact, that the actinomyces, including MAP, are actually much more significantly more reactive to NOD2 receptor up here than they are for E. coli or Salmonella. So this is the peptidoglycan of here works a little bit, but MAP works 100 times better, 25 to 100 times better. So the inference is that NOD is in fact the primary human measurement of detection system for intracellular mycobacteria, and therefore it's important, and therefore it implicates MAP in Crohn's disease. We then take Gerben Verwerder's work from the University of Nijmegen, and he actually then taking human cells and putting MAP into human NOD2 negative cells, and he sees depletion of the cytokine responses that we looked at. So, what does all this mean? Okay, so you've got mutations in your NOD2 gene. You have less alpha defensin, therefore you get more entry of MAP. You have less stimulation of this NOD2 gene, therefore you get less cytokines. And you also get more persistence of MAP inside these cells. So we can hypothesize that if this is actually happening, we can measure it. We can see that humans with NOD mutations should